I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh, it's amazing.
Join co-hosts Jamie Rocci and Teresa Kenney as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone.
Hey everyone, and welcome to the Hormone Genius podcast. I'm here with my co-host Teresa Kenney, and today we're going to talk about menopause. So we've talked about perimenopause quite often, and we haven't had a specific episode only on menopause. And when I say menopause, we're really talking about the post-menopause area. So we'll be talking about hormone replacement therapy. We'll be talking about premature menopause. We'll be talking about ways to help manage symptoms and really just get down to the nitty gritty. So this is going to be a Q&A. So I get to ask Teresa all the questions that I have in my mind. She'll answer my questions, and hopefully this will satisfy our listeners' questions as well. Because again, this is an area that I am sure more people will start thinking more about. Perimenopause is more discussed than it was 10 years ago. And so I think, post-menopause will also be discussed. So I think it's just right around the bend. So thanks, Teresa, for being open to answering all my questions.
Absolutely. This is a big topic, and I treat a lot of menopause women. I would say at least it's probably a third of my practice. So I've gotten really, I don't know, you learn to finesse things over time. And with women, what you know is that not all women are the same. So each woman that comes to me has individual needs, and that's what we need to talk about. And I think, calling this almost like a troubleshooting, because I think women do feel like there's just an array of different topics around menopause, an array of different questions and concerns around menopause hormone therapy. So we're going to dig in and try to get to the nitty gritty of how does this really work, especially when you're going into a healthcare professional and you want to be able to have that conversation about what are my options, what's going to be best for me and my health, and how am I going to live a beautiful, long, healthy life beyond, 55, especially.
Right. Because, I'm sure the number of women that come to you and say, I've hit menopause and my life is different now. And I'm sure there have been a number of women that maybe feel like they're losing hope. And especially for women, think about the women who are seeing doctors who aren't trained in the way you're being trained. I mean, for women going in, just like, let's just say to the everyday doctor, what is the quote unquote standard of care? If a menopausal woman goes in to the doctor complaining of whatever symptoms she's having, how would just the typical doctor see those symptoms and how would they treat her?
Yeah, I mean, it is a little all over the board, but I would say for those who aren't necessarily trained in maybe a little bit more restorative, maybe a more holistic approach to hormones, oftentimes when women go in to broach the conversation around hormone therapy, many times they're still met with, and especially if they're making that transition more recently, the options of synthetic hormones. So, i.e. birth control products. So many women are offered still like an intrauterine device or a synthetic kind of oral contraceptive pill. And, recently, I feel like in the last few weeks, I've had a couple of patients come in who were put on, it is for menopause, a common treatment, but it was also the therapy that was used in the Women's Health Initiative for hormone therapy, which is still crazy to me, but they used Prempro, which is a natural estrogen, but with a synthetic progestin called levonorgestrel. So what women don't understand, and so this is often the issue, that woman particular that I'm thinking of, she thought she was on a bioidentical hormone therapy. And because their doctors aren't really schooled, you could say, even in that term, or don't like that term anyway, they aren't, the doctor might say, yeah, this is totally natural hormones, and the patient comes to me and I'm like, well, it's not, it's not really. And actually, in the Women's Health Initiative, they used that. And, there was no statistically significant risk of breast cancer with the estrogen patients that use estrogen only, but in that Prempro group or in the synthetic progestin, there was a slight increase, even though it was not statistically significant. And the world has known that possibly that it is the synthetic progestins that may be more linked to breast cancer. So point of my story is that most women would like to not have any risk of breast cancer. Like if you gave somebody a risk assessment and you're like, would you like this one or this one? Would you like the bioidentical versus the synthetic? And the bioidentical doesn't have any increased risk. They're going to choose that. And the problem is that these doctors still kind of are in that it's fine. It's, you'll be fine on it. This is the same thing basically. And it's not the same thing. It's not the equivalent to the hormones that we make in our body. And so it's frustrating for patients. It's frustrating for me. And so I encourage that patient to go back to her OBGYN to discuss that it is possible for her to get both bioidentical estrogen and bioidentical progesterone, and it'd be just as safe and effective as what she was taking, and also improve her quality of life even better.
Yeah. So to be clear, we are talking, they are no longer cycling. It's been a year of no period. They're in menopause, or menopause has hit and it's post-menopause, and they're still being prescribed the pill or a synthetic form of some hormone, or of the progestin and then the estrogen in the case you mentioned. Let's make sure our listeners understand these different terms, because again, it seems as though even the word menopause.
Mm-hmm.
So let's talk about truly what is, when we hear pre-menopause as compared to perimenopause, then we talk about menopause, post-menopause. Let's kind of clear that first so people know what we're building on. When we say pre-menopause, we're talking any time before menopause. That's what pre means. When you're 20, you're pre-menopause. When you're 30, you're pre-menopause. But perimenopause is right before menopause, or within 5 to 10 years before menopause, right? And then menopause is what, and how does that compare to postmenopause, and how do we help people remember these terms and what they mean?
Yeah, so menopause is basically you have been on 1 full year with no menstrual period and no bleeding, and so it's kind of like, seems so stupid, but it's like one day.
Yeah.
It's one day. It's the one day that you got to where you finally went 1 full year with no bleeding and you're at the appropriate age for menopause. And then everything after that is post-menopause.
Post-menopause. I feel like people don't know that. I don't even know if it was super clear to me up until, I don't know, a few years ago. And it could just be, semantics or whatever. When we say menopause, really we mean post-menopause. But when we care for that perimenopause woman, and then we care for the menopause or post-menopause woman, how do we care for these two groups of women in a similar way, but also in a different way?
Sure. So it is mostly, I feel like, similar, except that this is often when I say with a perimenopause woman, they're often still cycling. And so you have to navigate the cycle. And in replacement of hormones, that becomes a situation of, well, I don't want to make them have more bleeding or problems with their cycle in a sense. So you're trying to cooperate then with the cycle.
Mm-hmm.
Basically, and you can listen to our episode on the perimenopause to menopause transition, because we did go through kind of some strategies for hormone therapy, but you may not in perimenopause use what we would call traditional oral daily combined hormone therapy, meaning that you're taking the hormones every day,
mm-hmm.
or
right,
transdermal every day. It may be that you're still cycling the hormones. There might be some version of estrogen and progesterone that you're using, but you might be cycling it a little bit. Now, I tend to not use a lot of cycling estrogen. I will in some patients who have very severe symptoms, but not in every patient. A lot of times I'm using progesterone as the start, and then maybe some vaginal estrogen, and then kind of working it up to it. And that really is the point, Jamie, that a lot of this I want to talk about is that, when you're when you're at the point, you're coming to my office and you're looking at me and you're like, Teresa, I don't feel like myself. I'm 51 years old. My cycles are like very irregular. Maybe I had a period 4 months ago. I'm having hot flashes. I'm anxious. I'm not sleeping well at night. My libido is in the tank. I've gained weight for no reason. I am tired. my hair is falling out, my skin is dry, my eyes are dry, I'm having vaginal dryness. These are symptoms that generally bring the patient in the office. Now, what I like to talk about is like goals and priorities then, because for the most part, when women are hearing about hormones and like whether they should take them, they're thinking about those symptoms. I would like my weight gain to stop. I would like to feel better. I would like to sleep like a normal human being. I would like to not be so irritable. So that's the goal, right? So if we're talking about why we give hormone therapy for menopause, most often it's been thought that you're doing it because of the symptoms. You're treating the symptoms of menopause. And especially in light of the problem with the Women's Health Initiative is that from 2002 on, that is the only reason why we were told to give hormone therapy, which limited things. Because the thought was, well, hormones could be dangerous. You shouldn't use hormone therapy. And you should only do it if you're dying of hot flashes, and you should try everything else first before you do hormone therapy. Well, praise God, we're in a totally different pendulum swing from that, because now it's like, no, hormone therapy actually is better for those symptom managements, but also has all of these longevity benefits that apparently we totally messed up in, looking at this study. So I like to talk about both, because for women, and this will go into, I'm sure, questions you have about how long do you take hormone therapy and what's the strategy behind that, it's about the priorities and goals. Mm-hmm. Is that if I am looking at this as just getting through the transition, like I just want to get through these hot flashes, I just want to get through this period of time that these symptoms would affect me, which on average can be actually up to 10 years. But then you're saying to yourself, I'm only going to use it for that period of time. Most women, though, when I explain the whole story, which the whole story is, yes, it will make you feel like a human again. You will get symptom resolution. But here's the deal. You're going to also need to understand that this is going to reduce your cardiovascular risk, meaning that you'll have less risk of heart disease as an older woman. You'll have less risk of osteoporosis. It will improve your cognitive health and actually be a preventative of possible dementia. It actually decreases your overall mortality. Mm-hmm. So if that's the case, then it gets into the goals being different. This is now more of a replacement from a longevity standpoint. And it just frames the question of menopause hormone therapy into two areas. Again, symptom management. Am I using this for some other preventative health benefit? And I think when explained correctly, most patients are like, yeah, of course I don't want to get Alzheimer's like my grandma did. Of course I don't want to fall down the stairs and break my back and end up in a hospital and die months later. Mm-hmm. Of course I want to protect my heart health because I know that there's some heart family history risk. So women are very excited to hear that there is not just the benefit of quality of life, but there is these benefits of longevity, you could say, and health for a long, long time.
So in giving women HRT to help them with the transition, like you're saying, we're helping them with the symptoms. And then now when we're shifting now thinking, okay, it's not just symptoms, it's both and symptoms and longevity. The longevity would be, though, if they continue to take it, right? So talk about that. So you're saying, you're prescribing HRT for women open to it in that transition time. And I'm sure this varies, but generally around how long? Is like a year of transition time, 2 years of transition time? Do you stop and then see if the symptoms still remain? If they stop, do the symptoms tend to crop up, just not as severe? And then in thinking of longevity, how long, like let's say I'm going to Teresa and I'm 51 and just yesterday it's marked a year of no, there's no cycle. I've had no periods in the last year. I'm going to get on hormone replacement. How long would I start off taking that before I come back for a check up? And then what would be the plan thereafter if I wanted to think about symptoms and longevity?
So if you came to see me and that scenario existed, number one, because there's some trial and error with hormone therapy, menopause hormone therapy, you probably would see me in 3 to 6 months at a minimum in those first year, because it's likely that there would be some tweaking that would occur. And this is where, again, after I ask this, maybe you can ask me more questions about troubleshooting, kind of what actual therapies we do. But then I would say it's kind of, in order for me to prescribe menopause hormone therapy, we usually have to see patients once a year. Just like if you were on an antidepressant or any medication, we're going to see you once a year. You're going to have a physical, all of those things. But when you're saying the question of how long would the transition last, I would say, I think on average, it's 2 to 5 years at least. So if anybody were to stop in the first 5 years, my anecdotal experience would be that symptoms would return. It's not across the board, but it also depends on the severity of the symptoms and what symptoms were bothering the person the most. In terms of the question of longevity and kind of the question you might ask of how should I decide to stay or on this or not stay on this? I kind of looked at it as an every 5-year question, although it can be asked every year if you wanted it to. And that's really because, 5 years it's a long period of time, but life goes fast. And so you're asking the question, do I want to continue these longevity benefits for another 5 years? So if you're 60 and I say, yeah, well, I mean, how are you doing? You're feeling good. Your health is good. Your bones look good on a DEXA scan. We've addressed some kind of like heart health issues. And you say, well, I still want those benefits for another 5 years. Well, that would be completely reasonable because by then you're 65.
Right.
At 65, you re-ask the question, I'm doing good. I'm still exercising daily. I'm out, running around with my grandkids. I, still like to play pickleball. At 65, you would ask the question, do I still want to protect my bones and my heart and my brain? And honestly, like if you've been doing well on hormones, you probably would say, well, yeah, because I still want to play pickleball.
Yeah.
So it's kind of like, to me, an every 5-year question. Now you might get to the point, let's say you're 70 and you might say, Teresa, I'm really at the point where I would like to just be free of these treatments. And I'm also at the point where I realize I'm getting old and that it's okay to let the natural process of aging occur. And by 75 and by 80, I think I just want to live out the rest of my life without hormones. Mm-hmm. Now, I would be like, great, you made that decision. You understand why you're on the hormones at that point. We've had this conversation before, so you're able to make that informed consent decision. And also, you realize the ramifications of coming off. And you'll lose all the benefits of those hormones within 5 years. So you kind of go back to your baseline again. You'll lose your bone density, to the point where, it would have happened when you started the hormones and you would have lost bone density. You'll start to have some aging occur in the heart and things like that. But at 75, you're like, I'm okay with that. Mm-hmm. So that's the conversation I'd like to have with patients. But could someone reasonably still stay on it up until 80? It is possible. I just think it's so individualized, and mm-hmm. every person at 70 is so different, and really what has come up in their life that you just can't make blanket statements about any of this.
What's to keep someone from just being on it forever? Like, why wouldn't, like, if I'm feeling good and I'm like, no, I feel good, and I'm 70 and I'm like, no, just keep giving it to me. Like, what would keep somebody from just taking it forever?
Usually a health event.
Okay.
They do develop a cancer.
Okay.
Maybe it's not even a reproductive cancer. Maybe it's they got lymphoma or some other cancer. And then they just, at that point, the health event takes priority. Mm-hmm. It just happens. Everything else goes by the wayside.
I see.
So I would say a big health issue, big life change, something like that, where it just almost like they don't even do it purposefully. They just end up stopping.
Sure.
And once you're off of it for a certain amount of time, probably you're not going to go back on it.
So, okay. So let's say, I think you used this as an example a few weeks ago, at our hormone coach retreat, that a gal came in and maybe she was 65 or 70 or something. She went through menopause 15, 20 years ago. And she's like, give me hormones, and you're like, oh, do women come in after having been in menopause, or they're in their post-menopause era for 15 plus years, and they're like, hormones are the answer, please give that to me? And so explain a case where that has happened, and then what do you do and say to them?
Well, it's happening more and more because of social media, and like people are talking about menopause a lot and hormones a lot. In fact, I joke that often I'm getting these women that are having joint pains, like my hip hurts, my knee hurts, I'm 70, like, I think it's my hormones, and I'm like, I don't think that's quite where hip pain in 70 fits, but but it's great. And I love the fact that these women are learning, and it's sad too, because I get so frustrated by the fact that nobody offered them hormone therapy, or had this discussion with them earlier. And that's the sad truth, is that we don't have enough medical professionals trained in menopause care.
Yeah.
And so if no one brings it up, no one complains.
Yeah.
And what's so frustrating is, like, then when they hear that they could have protected their bones and their heart and their brain, they're like, nobody asked me the question if I would have want that.
Mm-hmm.
It was only going to be asked if you were dying of hot flashes, and finally a doctor would be like, fine, you can have estrogen, So it's so frustrating. I do think this will change over time, but in that situation, we have to be very careful. Because, and this is what I'll say is, well, you have been out of menopause for over 10 years. So the aging process has already occurred. What does that mean? Well, it means that you've lost bone density. It means that your heart has become less pliable, less soft. There might be some changes, especially if you had family history risk, where you could have developed plaque in your arteries, or, lose cardiovascular function. You might have cognitive, issues at this point. Your memory might not be as good. So the aging process has already occurred. And the big risk at that point, and it really comes down to more the cardiovascular thing, is that if we put a woman on estrogen after she's been off of it, or not had no estrogen in her body for many, many years, then there is a slight increased risk of provoking a cardiovascular, or what we call venous thrombosis event. And that has to just be really discussed with the patient. And this is so individualized. Like, if it's a completely healthy woman, and I've had these women, they're still working out in the gym. They eat healthy, they're clean, they're normal body weight. They just didn't know about the benefits of hormone therapy in menopause. And they're asking me, I might run some tests, clear their heart, and say, yeah, you have a chance of still getting some benefit out of this. Mm-hmm. And that's the real question of, will they get benefit? Because, they might get some symptom relief benefit, but would they still get the benefit of cardiovascular protection? That remains to be seen, or I guess studied, because we don't know always. What we have better data is that if you start it earlier, within 10 years of menopause, you do get a 40% reduction of cardiovascular disease. And so we just have to give the patient the opportunity to have informed consent when it comes to that. And number one, we do no harm first.
Right.
Do no harm first. And I would also lastly say, I would never put that particular woman on oral estrogen, because oral estrogen always has a higher risk of causing a clot. Mm. And it's only a 2, possibly to 4 times increase with these menopause products. But so it's small overall, but it still needs to be thought about. And we can reduce that risk almost completely. No one is willing to say 100% reduction, but almost completely, using a transdermal estrogen, like a patch or a gel or a cream, transdermal estrogen. So we would avoid oral estrogen. And anybody we thought was at higher risk, and this is true whether you're 65 or whether you're 52, if you're obese, you're diabetic, you have a history of blood clots, we would never use an oral estrogen for menopause hormone therapy. We would always defer to transdermal.
Well, that's perfect, because that was my question of, what are the risks? And so really the risks kind of follow the modality, or the mode in which they are getting the hormones. So talk about what are things that women may experience that aren't positive? Like, are there risks even in the transdermal, So I'd like to know, what are the risks? And then, what are the modes?
Okay. So for the most part, when we're talking about, and I don't prescribe synthetic hormones. So whenever I tell my patient, they're like, is this natural? And I'm always like, well, I don't prescribe any non-bioidentical hormones. So I live in a world of that. So I'm not going to refer to the non-bioidentical ones, because I don't prescribe them. But if we're talking about, and this is how you know it's bioidentical, the word is the hormone. The word is the hormone. So if you are getting a bioidentical product and we're talking about estrogen, the word is estradiol. So on the label of your prescription, it will say estradiol, and pretty much that's it. And the dose. If it's progesterone, it'll say progesterone, or micronized progesterone, but it won't say anything like weird, like some word like levonorgestrel or norethindrone, something like that. It's progesterone. So that's how you know it's bioidentical. It doesn't mean that it comes from a compounding pharmacy.
Right.
You know, we can get bioidentical hormones from the regular pharmacies, and that's preferred for most people because it is bioidentical and it's cost effective.
Right.
I use compounded medications, but I never want anyone to think, well, that's the only way you have to go, and that's the only way to get bioidentical hormones. Absolutely not true.
Mm.
So if we're talking about very standard treatments, you know, with estradiol, the side effects really are kind of more nuisance side effects. And you think about estrogen, and we've talked about estrogen dominance, Jamie, and those things. Like, what would be a nuisance side effects of estrogen? Breast tenderness, maybe a little bit of water retention, maybe an emotional change you didn't like you felt like emotional in a way that maybe you hadn't been feeling. Maybe, you know, but these are transient side effects and they tend to go away. Some people actually are sensitive to like the estrogen patch just because of adhesive, because it's like a sticker, you know, so we have to deal with that. Or maybe they like to take a bath every day. And so I'm like, how's that going to work? So they're going to do better with, you know, possibly an oral therapy, but maybe a gel that they rub on or a cream they rub on every day that doesn't have to stick. So those are, you know, the side effects, basically. When we talk about like bigger risks, again, with estrogen, transdermal, there may be a risk of blood clotting, but it's almost considered zero. So transdermal, hands down, safest. And this would apply also, Jamie, to vaginal estrogen, which is localized to the vaginal tissue, completely safe for every woman. And if you don't know this already, there's a 50% plus reduction in urogenital issues like urinary tract infections using any sort of localized vaginal estrogen, which, you know, there's a doctor right now, Dr. Rachel Rubin, who's been a lot of podcasts talking about this because she's a urologist and she's like on a mission to make sure that women are not undertreated in their vagina.
Yeah.
And I was also listening to a podcast that said, basically, you can tell the health of a postmenopausal woman in terms of if she's getting enough hormone therapy by her vagina. Like if your vagina is still atrophied, dry, and you're having discomfort with intercourse, but you're on hormone therapy, you're probably not on enough hormone therapy because the vagina should be comfortable and you shouldn't be getting UTIs and it shouldn't hurt when you have sex. So that's a kind of a marker, I think, that could be used for, am I getting enough? And that's going to get into question about dosing and blood tests too, but we'll kind of move on from there. But did I fully answer the question? So progesterone, the natural progesterone, there's no side effects of cancer. There's no side effects except that it makes you tired and dizzy. And every once in a while, because most women love it, progesterone, you know that, Jamie. Most women love it, right? We talk about it all the time. It's like the best natural sleep aid. Like I love handing out progesterone in menopause. Like this is going to make you sleep like a baby. You know, you're going to love it until there's that patient who doesn't love it. There's always an exception to the rule. And she's like, I hated the way I felt on that. I felt moody and PMSy and it kept me up at night, or it made me feel really dizzy and tired, you know. So there's always an exception, but most women love progesterone. And the last thing I'll say about the estrogen is that, you know, of course, there's that big question about breast cancer.
Right. And
it's really been debunked, but I always tell my patients, we can't say that there's no risk at all. We can't say that really because it just isn't enough studies on the bioidentical estrogens to like give that full assurance. Although we're very, very sure it doesn't increase the risk very much at all, if any, we can't say for sure. And that's true of science in general. There is no absolutes. But the risk really has been negated in terms of re-looking at the Women's Health Initiative. And again, there was this issue about that synthetic progestin. So I feel very confident in telling my patients, this will not provoke an estrogen-related cancer, or I'm going to rephrase that because I just misspoke when I said that. This would not provoke a breast cancer. People hear, and what I was thinking of is my patients who will say, my grandma had estrogen-related breast cancer. This is where this is going to go. Estrogen-related breast cancer. What do they mean? In their mind, what they mean is my grandma had breast cancer and it's because she took estrogen. And so that is very not true. When we say estrogen positive breast cancer, what we mean is that the receptor site on the tumor responds to estrogen, but it has nothing to do with what caused the cancer. And so that is a common confusion. So if you have a relative that had estrogen positive cancer, it is not something that discludes you from the ability to take estrogen therapy. I always tell my patients, like, I can't tell if you're going to have breast cancer. 1 in 7 of us are going to.
Mm-hmm.
And if you already are sitting here with a growing breast cancer, you know, before you start hormone therapy and then you start it and you just didn't know yet, would it make it grow? Maybe, if it's an estrogen positive breast cancer, because again, it has that receptor site, but it didn't cause the cancer. And I often think, like, these bioidentical hormones, why would they? You know, our body used them their entire reproductive existence. And in pregnancy, estrogen goes like levels like crazy high, and almost to the point where you're like, holy shnikes, like, I can't even believe they're that high. So why wouldn't we get breast cancer in pregnancy then?
Right. Yeah.
So it doesn't logically make sense that our body equivalent hormones would cause cancer. And I think studies have proven that now. It's really the synthetic stuff that is the problem.
Right. Yeah. I mean, I hear that all the time. Well, you know, and even my own grandma, she had, you know, estrogen positive breast cancer. And I was trying to explain it to my mom, but there's just that fear is so strong. It almost like doesn't matter. Like you say,
totally
you
true.
know, it almost like just doesn't even matter. Okay, so I do want to talk about labs. I want to talk about dosing, but I do really quick give like a little pitch, or speak to the people who are hearing this and maybe they're thinking, okay, I hear that hormone replacement therapy is good, but I still just don't really get why, you know, why it's that bad of a thing for my doctor to just prescribe me birth control. I mean, that has hormones and sure it's synthetic, but I mean, I'm feeling terrible. So like, what's the big difference between me being on birth control for my menopause symptoms and hormone? So give me like a pitch, like, but between choosing synthetic that the doctor's prescribing me versus hormone replacement, and then what that woman can actually just share with the doctor, make it like, give them that bit, because I'm 100% sure there's people thinking that right now.
Yeah. I mean, if you make an informed consent decision, and a lot of my patients do, about using any hormone product, and you feel good about that informed consent decision, I respect that. I'll give you a common scenario. The IUD, because many women who get to the age of menopause, you know, they've had bleeding issues. Maybe they had heavy periods in the few years before, or they had irregular bleeding. It's very common, right? So many of these doctors are putting in IUDs. The problem is that they don't tell them that those hormones go everywhere. They always like kind of say, well, it's just going to be in your uterus, you know, and that's just not true. Like, your uterus has holes out the sides, you know, like, hormones go everywhere. So if you have been told that an IUD only stays localized to you in your uterus or your womb, that is not true. That those hormones affect everything. So the pitch is that, I mean, obviously it comes down to also this question of fertility. Like, some women are still really scared of getting pregnant, you know, and maybe they're 51, 52, but you know, they've heard people get pregnant before, and there's that issue too. And so there's some questions around we have to talk about. I still think overwhelmingly there's still options without using synthetic birth control. Even if you have that concern about getting pregnant, there are ways to do this in a bioidentical way. And it all comes down to that. What do you want for your body? And I think when you explain the risks of birth control, which we've often done on this podcast, of inflammation increases, decreasing your testosterone level significantly, your androgenic levels, which have a significant impact on your energy, libido, motivation, mood, sleep. It also destroys like the gut lining, prevents nutrients from being absorbed. It does have a higher risk of what we think is breast cancer in these synthetic products. So when you go through those risks, as long as a person has informed consent and they're like, but I still think I do better on this drug or on this therapy, then we respect that. I have a lot of patients that want to just stay on sometimes on the therapy that they're on, like a birth control or an IUD, until a certain point, until I hit 53 or 54. And I feel like I'm ready to get rid of it. And again, I might give them the benefits of bioidentical hormones, and we still might be able to use some bioidentical hormones with their synthetic hormone, but it's ultimately up to them, and having that conversation of informed consent about what is best for you and your situation and your body. And really what, again, it comes down to the priorities and goals too. What are you trying to get out of this? Because in my opinion, the bioidentical hormones are going to be way better for long-term health, right?
Yeah.
I mean, I would never, and I don't think there's a lot of women that want synthetic hormones at 60 and 65. Most women just don't even know they're synthetic.
Right. Yeah, totally. Okay, so you're working with a woman and you're going to do lab work. What are you looking for in particular? What do you often see?
Yeah.
And what are some common treatment plans? Maybe even beyond some of the HRT stuff.
Yeah, good thing to bring up because it isn't all about hormones. Like feeling good and having good like longevity is just not replacing hormones. I mean, if you have a crappy diet and you don't sleep and whatever, I mean, hormones ain't going to fix all that.
Mm-hmm.
So that's really important to bring up, Jamie. So when we do lab work and we're trying to just make the diagnosis, so there's two ways to look at this. Am I just making the diagnosis and kind of getting an assessment? Are you in menopause versus therapeutic kind of results afterwards, like maintaining health after that in terms of what that looks like with labs? To make the diagnosis, we just have to see that the FSH, follicle stimulating hormone, is high now, generally above 35, but usually it goes even above 50 to make the diagnosis of menopause, because that means the ovaries and the brain are not communicating anymore. That the estrogen is now below 15, which is basically zero. So your estrogen is plummeted to almost a zero state. And progesterone would also be zero because you're not ovulating anymore. And then the androgens can be variable. So you can have some women in menopause where like testosterone levels are normal, DHEAS is normal, and you can have some that are also very low, and that can be addressed separately. And we can talk about that too. So those are kind of the main hormones. Oh, and thyroid, we would assess thyroid, right? And I always assess nutrient status. We're going to look at B12, at whether their iron levels are stable. You can still do like, magnesium and zinc RBC. So there's some other labs we're going to look at, but a full thyroid panel often is very important because you don't want to miss hypothyroidism and think it's related to menopause. So there'd be those levels. So we make that kind of like all around baseline labs. Then when we have patients on hormone therapy, we go low and slow. This is really important, Jamie, low and slow. You don't need to hit them over the head with hormones right away. Women generally prefer to low and slow because they need to ease into it because they don't want to have breast tenderness or side effects or bleeding from hormone therapy. So you go low and slow. And again, I often recommend either the transdermal patch for estrogen because it's covered by insurance. So transdermal estradiol with a micronized progesterone, which is the bioidentical form of progesterone. Those are like the foundation. We have to get the foundation right before we add in other things. Foundation of menopause hormone therapy is estrogen and progesterone if you have a uterus. But I always give progesterone even if you don't have a uterus. I always offer it because of the sleep benefits and the bone health benefits. But technically, if you don't have a uterus, you could just do estrogen therapy if that's what you want. But I always offer progesterone too. But that's the foundation of menopause hormone therapy. And we start with the lowest dose usually, and we work up from there. It doesn't mean we'll stay there. In terms of that, I never need to test progesterone levels after a patient's been on hormone therapy in menopause because I don't care really what the progesterone is. We're using that to either benefit the protection of the uterus and the womb, preventing the estrogen from building it up, or we're using it for quality of life symptoms. Estrogen and the androgens are more important to kind of continue to monitor. The reason we monitor estrogen is that we're trying to at least establish that we've gotten to a therapeutic level, especially if someone's wanting this for bone health. And that's where we have some better data on this, Jamie, is bone health. Mm-hmm. And it's thought that you need an estradiol of around 50 to upwards of 70 to really get the bone health benefits long-term. Now, I don't have all my patients head up to 50. Some of them I'm pretty happy if they get to 40. We're just trying to get them, I always say, out of the zero land.
Right.
And above 35 for sure would be ideal. But if we can get up to 50, 60, there's an assurance based on studies that would improve bone health. But it's variable. And a lot of these are observational studies and we don't have a lot of data on it. And there's no playbook for it in terms of, the kind of like guiding medical literature.
Right.
So this is very tailored to the patient. So we might increase the dose. Now, again, some patients choose oral estradiol, and that's fine if we've determined that the risk of cardiovascular events or clot risk is very low. And that makes it easy. It's very cheap. It's very effective, and it's bioidentical. So we might start at the lowest oral dose and work up from there. And that's really it. And so I monitor those androgen levels too, like testosterone and DHEA. If the DHEAS, which is an adrenal/ovarian hormone, which can plummet in some patients very low, we'll add some DHEA. I use very low doses, not anything extreme, to get the levels close to 100 or right above 100. And then with the testosterone, too, anything less than 15 for a serum total testosterone is a pretty low level. Anything less than 2.0 for a free testosterone is pretty low. And so then, those are additional treatments. And I don't do those until I usually get the foundation right. And those can be used for quality of life benefit and for bone health benefit, like muscle mass, bone health, libido, motivation, sleep. So, and that's a whole, I feel like, other podcast we can do on like testosterone therapy, basically.
Oh, I was just going to say, Teresa, because I know I have so many questions in my head and I'm like, I can't possibly get them all out in the time we have.
Yeah.
So we should do a 2.0 because today we're talking about HRT in menopause. I think we should talk about health just in menopause, like metabolic health in menopause and mental health in menopause. And of course, we talked about perimenopause and we have our perimenopause course, people. So even if you're in menopause and you're struggling and suffering, everything we talk about in the perimenopause course will benefit you. So for those of you not aware, we have a perimenopause course. It's very affordable, less than $100. It's like a program. So you have different lessons, and Teresa and I are talking about different cases, and we have recommendations, and it's very simple but very valuable. And you could go to our website, www.hormonegenius.com, and you'll see it right in front of your face. So if you're suffering and you're like, I just need good information because I feel wayward, go to our website and purchase that because again, there may be things that would help you so much in terms of lifestyle. And we do talk about some HRT stuff too. We do a whole lesson on it. So that's kind of like a good second step. But Teresa, before we wrap up, because we talked about so much, and again, I do want to do another episode where we talk about some of these other things in terms of lifestyle and living and specifically for the menopause woman. But let's talk about premature menopause because there may be women personally who've, they've had a hysterectomy at maybe even a young age. So premature menopause, surgical menopause, clear the air with that. And I know we've talked about this before, but I think bringing it into this episode would make it really clear. What happens if they just remove the uterus? What happens if they remove everything, So let's talk about what premature menopause is, what surgical menopause is, and things to consider if maybe our listener or someone they know has gone through that or will be soon.
Yeah. And before I do, I'm just going to quick mention our sponsors too. We Heart Nutrition. Great. I just actually showed one of my menopause ladies yesterday, the whole package around We Heart Nutrition, because you can bundle their different things. And I said, this is what you need. You need a multivitamin for 40 plus, you need a magnesium glycinate, and you need their omega-3s. And that was it. I'm like, go to We Heart Nutrition. These supplements are high quality. They're going to give you some benefit over time for your health. Absolutely. And you can get 20% off, right, Jamie? So 20% off with our code GENIUS for We Heart Nutrition, 20% off. Secondly, I just want to mention Grazing Beauty Tallow. And I've mentioned that a lot to my patients because they come in menopause with dry skin and they feel like there's nothing that will hydrate their skin. I'm like, have you ever tried tallow? And one of the products that I love is just their kind of like lotion, basically. It's a tallow-based lotion. It just hydrates the skin so well. It can get rid of eczema, itchiness, dryness. There's kids who have been healed of their eczema with it. Grazingbeauty.com, and you can get 10% off with our code HormoneGenius. And lastly, Wonder Cow Colostrum, we talk about a ton for gut health. Really, also, gut health can be an issue in our menopause ladies as well because they're having such hormonal shifts which affect the gut. Mm-hmm. And so we have to do things to support the gut. And Wonder Cow Colostrum, we have validated in taking it ourselves, but we love their company and their mission. They're high quality. Go to wondercow.com and use the code HormoneGenius for 30% off our subscription there. Okay, so premature menopause, Jamie. So basically, it's like, as you can imagine, kind of going into menopause before 40. I think that's what the definition is. It could be a little bit younger than that, but it's definitely before 40. And so you're not expecting to be in menopause, right? Most people think they're going to go into menopause closer to 50. And so when that happens, this is significant. And I would say that surgical menopause is very similar because in premature menopause, there's an abrupt stopping of ovarian hormone production. You know that because the woman is having hot flashes and symptoms of menopause and they're not expecting that and they have no periods. And then you do a blood test. And just like I said before, the FSH is super high and the estrogen is super low. So that's how you make the diagnosis of premature menopause. But also in surgical menopause, if someone were to take your uterus out and your ovaries, you're going to have an abrupt menopause. It's going to be quickly an FSH high and estrogen back down to 0. And those, if done early, kind of before the age of 40 especially, but even in the early 40s, have significant profound effects on quality of life and on long-term health. And they've done studies that women have had hysterectomies early and taken their ovaries, they die earlier. They have more cardiovascular disease, they have more mortality, issues. It's just not good unless you can really, really help them and get them on hormone therapy. And this is a passion of mine. You have got to treat these patients. And there are doctors that just let them go without hormones. And that is not good. It's not good for them as a human being. It's not good for their longevity and health. So they would be candidates for the same hormones that we're talking about, the foundation of estrogen and progesterone, and then other hormones possibly in addition to that. When they're younger, you're more likely to use stronger hormones with higher dosages. Even if it's the patch or oral estrogen, you're going to use higher levels because they're supposed to be having higher levels, but they just prematurely lost them. So you might use if it's oral estrogen, upwards of 1.5 to 2 milligrams or higher of oral estrogen, or you might use the patch at 75 micrograms to 1 full milligram. So these women need more support because you don't want them to become osteoporotic at 50. Now, premature menopause, obviously very sad from a loss of fertility if someone was hoping to have a pregnancy. It's also kind of difficult because it's also a situation where sometimes with premature ovarian failure, you can have some spontaneous ovulations that still can occur within a certain amount of time. So there is this thought, are you fertile? Are you not fertile? And unfortunately, there's no guarantee because there is some incidence, like I said, of premature ovarian failure, people having some spontaneous ovulations. And I've seen that.
Wow.
They can still need to chart, basically, if they're using a natural method to avoid pregnancy, they still kind of have to watch things. So that's kind of an interesting topic, kind of an aside too. But that's kind of what the hormone therapy looks like. It's kind of the same, but you might be using higher dosages of hormones and getting them to those therapeutic levels like we talked about, 60 or above for an estrogen, because again, if they're in premature loss of hormones, then they're going to need that more restorative therapeutic level. And then the last one you said was the hysterectomy with leaving ovaries, which sometimes women are unclear. They're like, I think I have my ovaries. I think they left one ovary. I don't know. So you got to be clear. You got to ask your surgeon, what did you take out? But if they left your ovaries, the thought is that you would still have ovarian hormone production, and most women will have ovarian hormone production, but you kind of have to watch it. So if you have a big symptom change, like hot flashes all of a sudden, you better go get your levels checked because you don't have a period anymore to be able to gauge whether you're in menopause. You're going to have to get those levels checked. I would also say that women who have had a hysterectomy, who still have their ovaries, sometimes still need help. They don't feel the same. They feel that something changed when you took out my uterus, even though you left my ovaries and supposedly you told me it was all going to be just fine. They know it's not just fine. And so they'll come to me and be like, Teresa, ever since I had my hysterectomy at 41, 42, or whatever it was, I just don't feel the same. I started to gain weight. I started to feel more irritable, more PMS. I don't sleep as well at night. My libido's in the tank. And we address those with hormones and to optimize them and to really strategize their quality of life at that point.
Yeah. I just think about, I feel like I see this all the time, but I'm in a Facebook group for our local community. There's moms of the St. Louis community. I don't live in St. Louis, or moms of the Minneapolis community or whatever. So just this public Facebook group that I'm a part of. And so sometimes I see, posts that have to do with hormones. And it's just interesting because just last week I came across a post and it was like, hey guys, my doctor wants to do a hysterectomy, but he gave me the option of also removing my 2 ovaries and tell me, what are your thoughts? And everyone's like, just take them all out, just everything, do it all at once. You don't want ovarian cancer, might as well reduce the risk. Just take it all out. And I'm like, Lord have mercy. That's the worst advice. You know what I mean?
Totally.
No one knows. No one gets it. They just think, how the tonsils, you're like, what's the deal? Or your appendix, why do these things exist? We'll learn more as we, but I think people just think it's like a, just take
Yeah.
it. Just take it.
Yeah.
They don't understand.
They don't. That is so true, Jamie. They don't. And, that it goes me to say, I mean, you and I have been looking because Natural Womanhood puts out a lot of articles and they do a lot of stuff about birth control and things like that, but they actually have a lot of articles on menopause too.
Yeah.
We were surprised to see that. So if you're looking for more information about hormones in general, but for menopause too, I found one that said that we now get more hot flashes than our grandmothers and great grandmothers do. That just in surveys, these aren't, trials, but there's surveys that show that we're getting more hot flashes. So then it begs the question of why. And this is like the bigger thing, and this will go to our 2.0 episode on lifestyle, is what are all the things that are impacting our menopause?
Yeah.
And we know that like our toxins in our environment, the stress levels that we have, the ultra processed foods, these other factors are making our menopause worse. Yeah. And I would say that it's also making our mental health worse, the social media. I mean, I can't tell you, Jamie, how many times I'm like, listen, women want to figure things out. They want to figure things out more than anything. And the figuring things out part is driving them into a spiral of chaos of mental health that I cannot tell you. I'm like, we need to step back. Like life is really short, and yes, we're going to address how you feel, but stop trying to figure it out. There is not some Instagram reel that you're going to find that has the magic solution to fix all of this. I promise you that. Yes, people have good things. They're saying good things. Eat more protein, lift weights, do these things, but nobody has some sort of a concoction to make this all better for you. And you are individual, and each little thing that you do will either work or it won't work, whether the Instagram reel said it'll work for everybody. Yeah. And that's why women, they lose their minds about this stuff, because they're like, I'm doing all the things. I'm doing all the things. And here I am. And I'm like, I'm still 15 pounds heavier than I want to be, and I'm like, it's okay. Like, let's just take it one step at a time. Stop trying to figure this out. Like, take a deep breath. And the last thing, Jamie, I'll say is like, you have to believe in your treatment. And when summarizing kind of the menopause hormone therapy, I always say this: if you have some like person in the back of your head or sitting on your shoulder going, this is dangerous, this is bad, you're going to get cancer from this. Right. And you're like, okay, Teresa, give me the hormones. I think you told me all the things, I'm ready. But it's this person on his shoulder is going, you're going to get cancer. And you believe the person on the shoulder, right? I'm not giving it to you. Yeah. Because if you don't believe hand-heartedly that this is safe and it's going to help you and your health in the long run, you have to believe in the treatment. That is true of anything. And whether or not it's some placebo effect that you're going to get, that's good. Placebo effects are good. Yeah. But if you believe something is not good for you, I assure you it will not be good for you.
Teresa, we're going to do so we're going to do a 2.0 on this episode, but we have to do an episode on kind of our limbic system and rewiring. I came across this gal who does a bunch of work and like people are like literally healed of Lyme's disease, mold toxicity, their chronic fatigue, blah, blah, like give a list of all the symptoms because of how they're handling their thoughts. And when we think a certain thing and when we obsess and when we become neurotic, it affects our nervous system and it forces us into the same state of that sympathetic dominance that decreases our ability to fight these things. Even food sensitivities, you'd think, how could food sensitivities be handled through literally trying to like rewire our neural pathways in our brain? But we're all like, everything is connected. Yes. And we know 90% of the thoughts we have today were the same thoughts we had yesterday. So we're stuck. People are stuck. And I personally, sometimes I feel stuck, and when I'm struggling with something, we all kind of can feel that way during seasons of life where you're like, well, A plus B equals C. That's how science works, right? Although you're like, nope, science isn't math, which I think is important. So it is important to be flexible. It's important to know that our thoughts matter. And we will do an episode on that because I think there's so much more to that in regards to our physical health than we probably all even realize. So I'll have to do that.
Yeah. And in 2.0, we're going to do it soon, Jamie. We got to do it. Yeah. Because the one thing also that I need, so stupid. I'm like, this is the one thing I wanted to address in this episode. And guess what? We ran out of time. And that's like how to navigate spotting in menopause therapy.
Oh, yeah.
How do you navigate the world of like, now I'm spotting and I hadn't bled in over a year. And what do I do with that? So Jamie and I will record 2.0 soon, so we can make sure that we can release these pretty close to each other. And we'll make note menopause, bleeding and how to deal with that. And then we're going to go through testosterone therapy a little bit more, I think would be good. And anything else you want to talk about with the limbic system and just other lifestyle things to bring in. So I look forward to that, Jamie. I know you will too. And we'll see you real soon.
All right. Later, Teresa.
Thanks for listening to the Hormone Genius podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel. So if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.